Good evening, everyone. Welcome to Grand Rounds. Whether you're here in Rangos or viewing online, we're so glad you're here for this lecture. Dr. Daniel Lindberg is here today to speak for Grand Rounds and also to give the keynote address for our annual Pittsburgh Conference on Child Maltreatment, which is today and tomorrow. One brief announcement before introducing Dr. Lindberg. If anyone is available tomorrow afternoon and needs to get their Act 31 training for their license renewal, you are welcome to come down to Station Square at 1:15 in the waterfront room. Your training will get submitted directly to the State Licensure Board. We can't give you CME unless you're actually registered and paid for the conference, but we will give you the Act 31 that you need for your license for free. So feel free to come down. Dr. Dan Lindberg is a general emergency physician and a child abuse consultant at the University of Hospital Colorado. Children's Hospital Colorado, and the Kemp Center for the Prevention and Treatment of Child Abuse and Neglect. His research is focused on making the evaluation of child physical abuse by frontline providers more effective, safe, and fair. Over the last 20 years, Dr. Lindberg has been on a leadership team of 3 prospective multi-center research networks to test a variety of approaches to child abuse diagnosis. His work has influenced guidelines to identify occult abdominal injuries in children with suspected physical abuse and has affected current practice for the evaluation of children who live in homes with other abused children. He is currently a co-PI on the first NIH-funded child abuse pediatric research network called CAPNet, which is focused on improving the evidence base in child physical abuse. He serves as the steering committee chair of CAPNet, of which Children's Hospital of Pittsburgh is a participant. Dan is truly a leader in our field, and we are honored to have him here today. So please help me in welcoming Dr. Lindberg.
Thanks very much for having me, and thanks for that kind introduction. I hope you'll forgive me if at times during this talk I'm a little bit nervous. It is not an exaggeration to say that there's no one in the world who's contributed more to the literature on the medical care of children with child abuse than Rachel Berger, and she's sitting in the front row, and I'll probably be citing some of her work, and I know that she's influenced a lot of my understanding and belief about this field. It's not an exaggeration to say that there's not a program in the world that is more modern or more advanced than UPMC, Children's Hospital of Pittsburgh. And so it may be a little awkward for some guy from out of town to talk about how you guys are doing such a great job, but you're doing a great job. So please continue to lead the field, and hopefully I can bring something to the discussion. Just to set expectations, I'm not going to reveal any futuristic technology today. I haven't stolen anything from the aliens. I don't have anything that you guys haven't been doing, or not very much anyway. And I think a lot of other institutions can benefit from the advances of that the program at Pittsburgh has pioneered. But I am going to take a few minutes to review some of these recent advances, and I'd like to take most of the time to think about how and why each of the technological advances has changed the way that we think about child abuse pediatrics, because I'm not sure we've shared that widely outside of the field itself. You know, it's probably too simple to say that the printing press led to the Reformation, or that the Model T led to the suburbs, or that Twitter created QAnon. But technological advances that have been significant have been the most significant because they change the way that we think about a field. And I think it's reasonable to think about that for child abuse pediatrics. So everyone tells you that raising your kids goes by really fast. No one warns you about that for your early career. And I just realized it a couple of weeks ago. I blinked and it had been 20 years since I was an intern. And I actually thought back to a time when I was an intern. I was working in the emergency department. It was late at night. There was something of a lull. And one of my most senior physicians, Mel Otten, who learned emergency medicine first as a medic in the Vietnam War, he told us some things that they had done in his early career. He told us that if you were in a car crash and you weren't going to make it, no one died without us doing a thoracotomy and massaging someone's heart. He talked about times when they used insulin to treat heart attacks. And just when we were feeling the way you're feeling now, like, oh my gosh, that seems so old fashioned. What a great story. Ha ha. Thanks for the story, Dr. Otten. he did that thing that he does, and he made it really more profound. And he looked at us and said, all right, I want you to ask yourself, what's something you did today that you're going to tell your interns, when you're about to retire, and you're not going to believe that you did it. And he challenged us to think about the ways that we needed to change, that we needed to modernize. And I'm finally at a point in my career where I can look back on that and say, yeah, quite a bit has changed. And it's not just that we did something as crazy as writing something down on a piece of paper that would affect someone's medical care, legible or not. And that seems really odd right now, but it's really changed the way that we think about medicine. I also want to say that medicine generally and child abuse pediatrics in specific is definitely not the first field to be affected by changes in technology, right? We're probably the last field that's going to get disrupted, right? We can't move fast and break things the way you can if you're, a ride sharing service. And so again, none of this technology is going to be super new, but let's see what we can learn for how we think. So I have a few disclosures, which you can see here. The most important one is that my opinions are my opinions. I don't speak for anybody else, and certainly not my funders, certainly not the U.S. Department of Defense. I want to talk really, so first I'm going to go through some of the technological advances, and then I'm going to talk about how they've changed the way that at least I think about child abuse pediatrics. I think it's changing the way the world is thinking about child abuse pediatrics. And the three that I'm going to talk about are decreasing radiation exposure with new radiology techniques, information sharing, and then leveraging the electronic health record. So physical abuse in children, at least, is overwhelmingly a disease of the youngest infants, and radiation exposure is a big deal on these kids. And we've recently seen the development of two tools that can substantially decrease the amount of radiation we use, and then one piece of information that just helps us know that we're not exposing kids to radiation for our typical tests. So the first innovation is low-dose CT. And again, it's not a new invention. It's not like you need a new scanner. It's just optimizing your protocols for children and for bones, especially in the chest. So dosing protocols now can make a CT scan of the chest a reasonable comparator to the best alternative, which is a follow-up skeletal survey in 2 weeks. They still have slightly more radiation, but in exchange for not having to wait for 2 weeks, it's a reasonable trade-off. Because especially when you're dealing with the youngest children, just saying, all right, we need to take you out of the home for 2 weeks until we get a follow-up skeletal survey, it's a pretty big deal. That said, I still use low-dose CT pretty sparingly because even though finding one rib fracture can be a really big deal for the determination of whether or not a child is abused, finding another rib fracture is not usually that big of a deal, and it's certainly nothing that we're going to treat clinically. But the other piece of information that we see is that the dose of a typical skeletal survey is actually really low. It's about the amount of radiation that my kids get because we live in Denver instead of where we used to live, which is Boston, in a month. And so, it's the sort of thing that we've now got that information. Oh, by the way, if you're in the audience, every time I say Rachel Berger's name, you have to drink. And this is one of those times. So Rachel was the lead of one of the best studies that show us this is a pretty low dose. It's pretty reasonable. And so getting a skeletal survey is a pretty small thing. The other technology here is fast MRI. You also have to drink with this, but other people have done the studies. And this is something that we use a lot more than low-dose CT for the chest. And my understanding is that's true here in Pittsburgh as well. In Colorado, a fast MRI is our first-line study for stable kids where we're worried about a brain injury and abuse. And actually, we're starting to use it more and more for stable kids where we're worried about a brain injury from anything. The data on fast MRI are pretty compelling in terms of feasibility. It doesn't require radiation. It doesn't require sedation. It takes about 6 minutes. And when we did our study of about 225 kids who had a head CT ordered and then tried fast MRI in those kids, we were able to get it in 223 of those kids. One kid was vomiting and just couldn't hold still, and the parents asked us to stop, and one was crying and they asked us to stop. And so it's a pretty feasible study. It's worse for bones. And so if you're looking for skull fractures, fast MRI is not the best test. but it's better for looking at the subdural space and the parenchyma. And personally, that's where I think the money is, both clinically and forensically. And so we use a lot of fast MRIs. So when you put that all together, skeletal surveys don't involve a lot of radiation, fast MRIs are very feasible, and low-dose chest CTs can be done for the price of about the radiographic price of a skeletal survey. What this means is that the risk profile for most occult injury testing is pretty cheap, right? And so one of the easiest decisions now in child abuse pediatrics is to look for occult injuries. Abdominal injuries are the exception. We still need to find a tool for that. Abdominal CTs are a fair amount of radiation, but other than that, one of the ways it's changed our field is that we don't think really hard in many, many cases about whether or not to get occult injury testing if we're really not sure. The biggest questions now are, when it's really low risk, are there low enough risk kids that we can avoid this testing for a whole group of kids? But if you're actually struggling, getting a occult injury workup is pretty straightforward. So moving on from radiology, the next big advances in our field have been much larger data sets, and that means multi-center studies. So I know it's like the guy from out of town is coming in and talking about this new idea of an adequately powered study. Ooh, right. Okay, I know everybody else has been doing adequately powered studies for thousands of years, but it's actually a new phenomenon for child abuse pediatrics. So just as a reminder, board certified child abuse pediatricians have only been around since 2009. And even the busiest centers have a hard time getting enough cases for child abuse that are the same, right? Child abuse is super common. It happens to lots of kids. You know, even in a room where most people are online, there's probably someone just playing the numbers who's experienced abuse in this small room. So it's super common, but it's so diverse that it's hard to get an adequate sample, right? So when you talk about people with cancer, lots of people get cancer, but if you're trying to do a study on angiosarcoma, it's a little harder to get that sample. So abusive head trauma, probably one of the most serious, one of the most studied parts of child abuse pediatrics because it's the most deadly. Even a place like Pittsburgh or Colorado is probably going to see 45 or 50 cases a year tops. That's 50 cases too many, but it's not enough to do a big study on treatment or identification. And then on top of that, the need for multi-center studies comes not just from getting sample size, but because we really practice in different worlds when it comes to some really important things like how the Child Protective Services agencies and other care organizations, law enforcement, deal with kids. And the response I'm going to get in Denver may be extremely different from what you'll get in Pittsburgh. And we can't publish generalizable recommendations unless we include both of those sorts of things. And so for these reasons, we've only just recently begun to collect these large samples in the last 20 years. I'm going to talk a little bit about CAPNet, which, as Rachel mentioned, is one of the networks that I'm currently affiliated with. It's 11 sites, and it includes Pittsburgh and Children's Colorado. And unlike other multi-center studies, which have had big impacts on the field, CAPNet wasn't designed to answer a question. And you might in the audience be thinking, well, that seems like kind of a mistake. CAPNet was designed to answer a bunch of questions, right? So many other studies like PD burn or 10-4 faces P have had one question in mind and have spawned a lot of different research questions that use their data. CAPNet was designed purposely to be more generalizable. We have 11 sites, we have about 4,000 consultations a year, and it's designed to be a tool for everyone. So if there's someone in the audience who has a question or runs into something in their clinical practice and says, I'd like to get multi-center data about this, that's what CAPNet is for. And you can call Dr. Berger if you have questions. I understand that she's available for texts anytime, day or night, weekends. She's happy to hear about this sort of thing. She can get you started. Beyond the multi-center studies that look specifically at child abuse pediatrics, of course, we have at the larger scale administrative data, databases like FIS, NEDS, and HCUP. And you can see some of these data that were done by Dr. Wood's team. But I warn you, if you're thinking about doing that, there's a big limitation for these studies, which is how do you count abuse, right? If you count everything else in medicine, you do use ICD codes, right? If you want to find kids with sepsis or pneumonia, it's not perfect, but it's a good start. The problem is the diagnosis, with scare quotes, of abuse is often made long after you have to submit your medical bill. And I tell my residents, it's not really important to have a diagnosis of abuse by the time a child leaves an emergency department. And often it's not possible or important to have a billing diagnosis of abuse when the child leaves the hospital. And so you have to find other ways to count that. At the same time, we are finally starting to see some information sharing across different systems to handle this issue of identifying abuse. So it's been an almost universal problem for child abuse pediatrics research that is limited to the outcomes that are measurable within a single healthcare system or even within a single healthcare visit. And so if a child with a sentinel injury doesn't come back to your hospital, you may not know that they had a bad outcome from their abuse after their abuse several months later. And so we actually have reason to believe that in families who are experiencing violence, they're more likely to go to different hospitals and shop for different healthcare systems than other families who are dealing with chronic or escalating diseases. And we're finally starting to see some information sharing between medical data, social services, law enforcement, policy, education. We still need to do much more, but it's finally starting to happen. And then finally, in the data space, the next advance is data linkage. Again, people have been doing this for years, but it's finally starting to come to child abuse pediatrics. And we're able to leverage probabilistic linkage methods to identify the same children in different data sets. So if they're in a medical system versus CPS or in law enforcement, and then multiple people in the same system. So, it's no problem if you read a note from the child protection team at Pittsburgh to identify who lives in the home. But if you want to do research on that, it's really hard to do that at scale. And we're just finally being able to link people across families and households at a big scale, not by reading one chart at a time. The final major advance that I want to talk about before I talk about the way it's changing the way we think is the electronic health record. And when Dr. Otten challenged me to think, what are you doing today that you'll think is crazy in 20 or 40 years? I thought writing stuff down on paper and having, dealing with a patient without even getting a flag that says, you just wrote them for penicillin, they're allergic to penicillin, seems crazy now. And so I was right. That's the moral. If you take one thing away from this lecture, it's that 20 years ago I was right about something. But I think no one could conceive at that point, and I think we're still conceiving how the electronic health record is changing the way we approach every single patient and certainly abuse. And this is the part where I get especially nervous because I know that no other system in the country does a better job of leveraging their electronic health records to screen for children, especially with physical abuse. So this screen will certainly be familiar to many of you who work in the emergency department or with the child protection team. For those who don't, this is the screening program that was pioneered here to screen children less than 13 years old for signs of physical abuse. And so every kid who's less than 13 who needs emergency care, their nurse will be prompted to ask themselves these questions about whether or not there are signs of injury, to do a head-to-toe physical exam, if there are sentinel injuries, if there's inconsistency in the history, and to prompt this. And Dr. Berger's team, We All Have to Drink, has shown that this is feasible. It can be done pretty quickly. It's well accepted. It doesn't, ruin your emergency department. It's not disruptive to the flow of patients to the emergency department. And when it's positive, which is not commonly, the kids are at pretty high risk for abuse, and so it's worthwhile doing. Now, we also have a routine screening program in our network of general EDs, and recently we had the opportunity to do a bit of a natural experiment on this because our network of 27 general emergency departments decided to implement this program of routine screening, which was a slight alteration to what y'all have. And then our children's hospital system, which was geographically similar, chose not to do that. And so we were able to link our hospital data with statewide data from CPS. So if someone comes to my emergency department in January and gets missed and sent home, and then in April has an episode of abuse and goes to a different hospital, We were still able to find that because we were able to link to our statewide system. The key differences you want to know about our system versus your system is we don't ask about neglect. And we don't have the same robust program that y'all have in terms of monitoring this. So my understanding is that if a kid screens positive on this and no one does anything about it, someone on the child protection team will know about that and look into that and maybe even call you back and go, what happened here? Why didn't you do anything about it? Ours is pretty much a plug and play, set it and forget it sort of system. It'll fire on people. It'll remind them, if I'm an emergency physician and my kid screened positive, I didn't know about that, I'm about to send them home, I'm going to get a big red flag that says, are you sure? But if I say, yes, I'm sure, that's the end of it. So our outcome was a child protective services referral in less than 6 months for moderate or severe physical abuse. So we were initially excited when in the post-screening period, rates of our main outcome dropped significantly. Our odds ratio was 0.8. Unfortunately, the centers that didn't implement the screening had an even bigger drop than we did. It was even statistically significant. So it makes you wonder, was the screening making things worse? So it's entirely possible that screening didn't work. It's entirely possible that our screening didn't work. And the difference in our program versus your program without the follow-up and the feedback is something that we really have to look into. I'm not advocating that we get rid of screening. And then there was this subtle confound that you may have heard about. Our screening program was deployed in October of 2019. And I don't know if you've heard, but in December of 2020 or March of 2020, something happened. And our pre-screening and our screening period is almost synonymous with our pre-pandemic and pandemic period. And it's entirely possible that this effect just swamped any effect of the screening. It's a little optimistic for me to say that because it looks like screening may have made things worse, but this is really new data and we have to look into it pretty closely. Our program also doesn't have a link to some of the slicker forms of abuse recognition like you guys have here. So in case there's anyone in the audience who doesn't work in the emergency department, once the screening program is positive or once there are other things in the electronic health record that may indicate that a child should be considered for abuse. So for example, if a 8-month-old gets a leg x-ray and then an order for an orthopedics consult, there should be a flag that says, hey, should you think about abuse? And here's a bunch of order sets that can help you do the same thing every time. And this is probably the most important new tool that defines a modern medical approach to child abuse, which is interactions with the electronic health record that'll help remind people and do the same thing every time. You can probably see where this is going next, and it's not ready for wide dissemination yet, but researchers, especially at Yale and then in collaboration with the group here and with us, are starting to use natural language processing to identify red flags and sentinel injuries. So as an emergency physician, I've always worried that the limitation here is that we fill out our charts after the patient leaves the emergency room, right? And so if a natural language processing program tells me, hey, that kid you saw yesterday was at risk for abuse and you should have done this test, that's not going to work. It's probably not even going to work if it tells me after I leave the room, having told the parents what my plan is. It's quite a barrier to say, okay, so I'll get you your discharge papers, and then 10 minutes later go, whoa, actually I have to do another test. It's kind of hard clinically to do that. But the more I see how my residents and my colleagues are charting contemporaneously, that may not be quite the barrier that I thought it was. And so natural language processing, I think it's going to be one of the areas to watch most closely. Paired with this, machine learning, and again, no surprise, Allegheny County is leading the way on this. It's starting to identify patterns in other data, linked data, associated with abuse risk. And so this is the program that I hope most of you have heard of, where the Child Protective Services System is using machine learning to identify data from outside systems like child protection and healthcare records to identify kids that are really at high risk at the point where CPS is deciding to screen in or screen out a referral. Importantly, at this stage, machine learning is paired with human beings. It doesn't make these high stakes decisions by themselves, but it does raise a flag that says, are you sure, to the human? And it's been, my understanding is it's pretty helpful and has not been shown to increase racial disparities, which I think is an important check, which I'm really glad the team has done. So basically, the tools that we've talked about is better sharing of data, better integration of data at the point of care in the electronic health record, and then a few lower dose radiation methods. So what does that mean for how we think about child abuse pediatrics? So people who trained around the time that I was initially training will remember a time when part of our training to recognize abuse was thinking about the person sitting across from you. So people would say, if the person has poor eye contact with you, if there's a couple there and the husband won't let his wife answer questions if he talks over her, if there's a poor interaction between the parent and the child, you should think about abuse. And there are problems with that in a couple different ways. And these new systems have helped us change the way we think about it. So we're thinking more about sentinel injuries. And it's been a long time since I've had someone talk to me about someone's affect. And there are a couple problems with using affect, because what it's really asking you to do is to decide, is the person across the table from me the sort of person who would abuse their child? And there's huge problems with that. Number one, we're not good at it, right? No one's good at it, and we in healthcare do not get trained for it. And for that reason, we missed abuse all the time. I think when people tell you, hey, if someone's talking over their wife and they won't let her talk and they keep interrupting her, they're meaning to say, hey, you should think about it. But unfortunately, because of the way we work as humans, it was often interpreted as, well, if I've got this child with a broken leg in front of me, but he's not interrupting her and they've got good eye contact, well, then I don't have to think about abuse. And for decades, we've lived in this space where really serious abuse got missed pretty frequently, about 30% of the time for abusive head trauma. And I think it had to do with the fact that we were looking for these things that were pretty uncommon and were not set up to find. But also, it has to do with bias, right? I'm probably the most overprivileged person in this country from all the categories of demographics that I'm in. And so I'm a little uncomfortable mentioning this, but I don't think it's controversial to say that different people approach stressful situations or any situations in culturally different ways. And if I bring my own cultural assumptions about what constitutes an appropriate affect and make high stakes decisions based on that, those decisions are going to be pretty biased. But the last problem is that it's really hard to go to work when part of your job is to decide whether the person sitting across from you is a good person or might abuse their kids. And that's something that's emotionally difficult for us, and it makes us hard to practice child abuse pediatrics. One example, for those of you who work in an emergency department, let's say your next patient is a 15-year-old young woman, and she comes in with lower abdominal pain. She says she's never had sex before. Who orders a pregnancy test? Right? Everybody orders a pregnancy test. It'd be wrong not to. Now, you don't say, well, what is she wearing? You know, does she seem like she's telling me the truth? Does she seem like an honest person? No, you just make the calculation that missing an ectopic pregnancy is really high risk, and doing an extra pregnancy test is really low risk. And so now that we have occult injury screening systems that are pretty low risk, and we know that child abuse, missing child abuse is pretty high risk, we've moved into a way of thinking that's based a lot more on sentinel injuries than it is based on our subjective impression of people. And while this is probably redundant for most of you, probably the best example of this is the 10-4 faces P rule, which was done, again, a result of the multi-center collaborations. It was led by Dr. Pierce out of Chicago. It's a pretty good mnemonic for the kinds of bruising that are high risk for abuse. And it's 96% sensitive and 87% specific for abuse in kids with bruising less than 4 years old. The other thing that the new technology helps us with is that this is something that child abuse pediatricians can remember off the top of their head because they think of it every day. But if you're a general emergency physician and 10% of your patients are kids and 1% of those kids are abused, and you're going to see abuse every year or so, you're probably not going to remember this off the top of your head the way you remember the heart score or, PE risk score. And so having the electronic health record prompt you on things like this and natural language recognition prompt you for these sorts of findings is really essential to making these tools work. Another example of this more consistent, sort of more routine, set the pathway, not deal with the exact patient approach is something of dogma. I don't have any data behind this, but it rhymes, which lets me know that God agrees with it, which is to and down and again. It's just making sure that everybody's naked when they're in the emergency department or even in their primary care physician's office if they're less than 2 years old. I think if anyone's looking for a quality improvement project and they're in a system where kids aren't routinely naked when they're examined, this is probably the biggest bang for the buck. And then the final outcome of this more routine way of thinking is a consistent workup where we don't have to think too hard about which tests we're ordering. We've got more routine approaches for occult injury testing. So along with this process of thinking of sentinel injuries, and then based on this idea of linking data across families and different systems, I think one of the next things that is included in a modern approach is thinking of family violence more as a disease which affects a household rather than a specific person. And so we have different fields that deal with intimate partner violence, child abuse, animal abuse, elder abuse, but more and more we're realizing that this is all one problem that has multiple different manifestations. So in my own work, we looked at asymptomatic children who lived in homes where abuse was identified in one child. And in young kids who live in those homes, the rate of hidden fractures is about 12%, even in well-appearing kids. And in those who are old enough to be asked about abuse, 30% reported abuse of themselves or of the contact child. And so while the number of rigorous studies is pretty low at this stage, whenever you find one kind of violence, the risk to other people who live in that home is quite high. And so when you make a list of findings that are sentinel injuries like 10-4 faces bruising, I have to think the presence of family violence has to be on that list. And we're actually finding that it's even a more robust predictor than most of the other injuries that we look at. So I do want to talk a little bit about how we got to this place, about how people started studying different forms of family violence. Animal abuse was actually studied closely about 100 years before anyone started looking at kids. This guy on the left here is Henry Berg, and he was frittering away his time doing something insignificant. He was the United States ambassador to Russia. So kind of a busy job, but he's in the middle of doing the ambassador thing, and he's going down the street and he sees a guy beating a horse almost to death because the horse won't move in the street. He gets out, intervenes, protects the horse. Next day, he resigns his job as the ambassador to Russia, comes back and founds the ASPCA because he thinks it's a more important thing to do. It's about 100 years later when Henry Kemp, who was a pediatric virologist, brought widespread attention to the problem of child abuse with the battered child syndrome. I should mention, under contractual obligation to mention that Henry Kemp invented the field as long as I work at the University of Colorado. So I believe that fulfills my commitment in this lecture. And so he started that in 1962. Efforts to improve the care of women who are dealing with intimate partner violence, and now, of course, not just women, but still predominantly women, were initially started as part of the Prohibition movement, and then it started again in the 1970s with equal rights and the women's liberation movement. And we're really only now starting to deal with the problem of elder abuse. And what do all these things have in common? Henry Berg got involved with the ASPCA because he knew something about animals and he cared about animals. Henry Kemp got involved in child abuse because he knew about kids, because he cared about kids. Women got involved with intimate partner violence because they know about women and they care about women. And the people who are leading the elder abuse movement are geriatricians. They know about elders and they care about elders. But I'm going to suggest that the problem here is not the kids or the animals or the elders or the women. The problem is the violence. And we're not going to find the solution to that problem because we know just about the victims. We really have to move to an approach to family violence that deals with the entire household. And one of the solutions that's growing from this new understanding of family violence is the idea of a family justice center. So family justice centers, at least in Colorado, are often started by prosecutors who are dealing with intimate partner violence cases. And they realize that the people who are dealing with intimate partner violence often simultaneously have to deal with the fact that they've got an injury and they need medical care. They've lost their housing. They need to protect their kids and their pets. They've lost an income and they don't know how to put food on the table. And they're dealing with law enforcement issues. And if each of those major life-altering problems requires you to go to a different place on a different day and spend the day dealing with someone, the thing that probably gets triaged is going to court and testifying against the person who hurt you. And so God bless them. The district attorneys have set up these family justice centers that co-locate all these services in the same area. I love this model. But it kills me that these were invented by prosecutors and that the price of admission for going to these places is often involvement in the family court system. And so when I try and ask myself Dr. Otten's question every year and ask, what am I doing? What will I be doing differently by the time I retire that'll make what I'm doing now look crazy? The fact that these family justice centers are part of the law enforcement system and not something that we're able to provide for everyone who's dealing with these issues just kills me. All right. So I'm presenting everything as if it's a universal advance towards a more perfect union in the future. And I need to be honest and just say that there are some downsides to a new modern approach. And yes, this has increased testing. And I know that that's uncomfortable. And for me to say that radiation is the only risk for testing is not telling the whole story. We can talk all day about the risk-benefit ratio of a skeletal survey and how it's far more favorable than a lumbar puncture and a febrile neonate. The real concern, both for families and doctors, is that a sense that the decision to embark on child abuse comes with some stigma. It comes with some judgment. It comes with an emotional burden that stems from the old way, right? So if a decision to pursue a child abuse workup is a manifestation of my judgment that you seem like the sort of person who might abuse your child, it's offensive and it's emotionally burdensome to deal with this. But if we've moved from a system where I'm not thinking so much about you, I'm just thinking about the injury you have, we haven't done a great job of communicating that to our patients who still may feel like that decision is a judgment on them. And so as we move forward with a modern, more objective approach to child abuse pediatrics, we need to communicate that if we're using less judgment, we're also being less judgmental. And so for my trainees who are early, they're doing their first child abuse evaluation, I like to share some scripting that tries to get beyond this. It's not there yet. And people are primed to believe that you're making this decision because of something about me, and often because of what my demographics are. And that's not an unreasonable assumption. It's not like it's never happened before. But the formula that I give to people is to focus on the injuries, not talk about the person, talk about how this is more than we expect, and that whenever we find something more than we expect, this is the sort of thing that we do, and try and be as transparent as possible when I have data. So when I have a rib fracture in a child, I can honestly say more than 85% of children in this age group who have rib fractures are ultimately found to be abused. And the other ones had major trauma like getting stepped on by a horse or hit by a car. And your child wasn't stepped on by a horse or hit by a car. And I try and share those numbers as best as I can. But I think that this modern approach also has to be consistent with decreasing the number of avoidable reports. This, again, is something that I'm hoping for in the future. It's not something we're doing today. In fact, this approach has, I think, contributed to a dramatic increase in reports by medical providers to Child Protective Services. So since child abuse pediatrics was established as a specialty in 2006, we've gone from being 8% of reports to CPS to being 12% of reports to CPS. We've increased much faster than all other reporters, all while our estimates of the rates of abuse seem to be going down. So it seems that we've really lowered our threshold to report. Now, for some reason, in some ways, that's a really good thing, right? So we're more likely to report children who live in a home with a child who's abused. And I think medical providers are less apt to see Child Protective Services as a dark agency that kicks your door down and steals your kids. I think we've done a better job of communicating the fact that CPS can be a supportive thing. But I think that that's also led to a dramatic lowering of our threshold to report. Now, I'm not asking you to turn the thermostat back down. I'm not asking you to be reluctant to report to CPS. If you're concerned for abuse, I still believe that CPS can be a very helpful agency. It's not a dark agency. But I think there's a few areas where we can also use our modern data collection to decrease a report. So for one thing, I do want to push back on the idea that I've heard from some people that once you think about abuse, don't think anymore, just file the report. That's not what the laws say. That's not the purpose of the laws. It's not any concern equals a reasonable concern. And where the rubber hits the road for me is I'll often say, okay, you've got this kid, they've got a minor injury. The mechanism seems plausible, but it's a sentinel injury. So get a skeletal survey. And if the skeletal survey is negative, I don't think you need to report to CPS. And some people will say, well, wait a second. The law says if I have a reasonable concern, I have to report to CPS. Getting a skeletal survey means I have a reasonable concern. Calling you means I have a reasonable concern. This is not something I have data for. I'm happy to have a conversation, but personally, I feel like there's some steps you can take to see if you should have a reasonable concern, including calling me, including getting a skeletal survey. And if I try and reassure you, if the skeletal survey is negative and you're reassured, I think that's below the reasonable suspicion threshold. And I'll just say that at least in my area, Child Protective Services agrees with me. The other things that I think where we can make a difference have to do with skull fractures. Most skull fractures are not abusive. If you have an isolated skull fracture, that can occur from birth. That can occur from extremely minor trauma. So I think it's reasonable to look for other injuries, certainly on physical exam, skeletal survey. But if you don't find anything, we in Colorado at least don't routinely report those to CPS. And then one of the biggest signals that we found in the early data from CAPNet was the idea that a lot of kids are getting a consult to a child abuse pediatrician and they're getting reported to CPS before that consult occurs. In about half those cases, the risk of abuse as estimated by the child abuse pediatrician is really quite low. And so I would wonder, what are the circumstances? There are some circumstances, certainly, where you need to get the report going quickly. But if you know a child is going to be seen by a child abuse pediatrician and your own subjective level of concern for abuse is, it could be, it could not be, in many cases, I think we can wait for that. There's one circumstance where we need to make a solution before we start changing that, and that is transfers, right? So transfers from one hospital to another hospital, often a general emergency department to a pediatric emergency department. So in Colorado, that often means flying over the mountains or driving over the mountains. It can be a 4-hour, 5-hour transfer. And the problem is, what if someone doesn't show up, right? So if an emergency physician says, well, I'm not sure if I should be concerned, but I'm sending them to Children's Colorado because I want them to see the child protection team. It'd be nice if we could say, oh, it's just a skull fracture, or we found some mimic, this isn't concerning for abuse, and save that family from getting any report. But if they don't show up, I don't want to be the guy who's on the hook for making a report to Child Protective Services because they didn't show up. I never saw them. I didn't have concern myself. But if we only realize that they didn't show up 8 hours after they were referred, that emergency physician is in no position to report. They're at home, they're asleep, they don't have access to the medical records, they don't have access to a social worker. And so that's the reason why most people will say, look, if you're transferring them to see me as a child abuse pediatrician, it's on you to report before you send them. But it's not an insurmountable problem. I think this is something that we as a healthcare community could solve, because there's actually a fair amount of reports that we could probably avoid if we just had a mechanism to report them if they didn't show up, but not if they did. Finally, with access to a bigger population, CAPS have realized that we're probably not the real solution to this problem. I think we're important, don't get me wrong, but finding cases one at a time, reporting them to CPS, teaching the cops and judges and juries about whether injuries are concerning about for abuse, it's not going to affect the health of a family, and it's certainly not going to affect the health of a society. It's important to save lives and protect that kid, and we should definitely keep doing it. But we have to learn from conservationists, and that's why I'm showing you a picture of an elephant. Because decades ago, conservationists learned that if you want to save the elephant, you can't just focus on the elephant. You have to save the jungle. And we as child abuse pediatricians have to do a better job of policy level solutions to protect our jungle. So this is data from Hank Pulse's group out of Kansas City, and it looks at total state spending on anti-poverty programs. Just so no one has to squint, the red arrow is Pennsylvania. There's a huge amount of variability state by state in the amount of money we spend per poor family on things like Medicaid, earned income tax credits, cash assistance, housing support, and similar programs. And what Hank's group showed was a pretty robust correlation between that sort of anti-poverty spending and the burden of abuse, both on reporting, substantiations, foster care placements, and even fatalities. For every $1,000 we spend extra per family, we can reduce the number of reports and substantiations by about 4%, the number of fatalities by about 8%. It doesn't pay for itself, but then again, there are other benefits to anti-poverty programs. The healthcare system is not alone in moving away from a system of investigation to a system of prevention and support. I'm really gratified that in Colorado, the Department of Human Services is leading the way away from a mentality of mandatory reporting to what they call a mandatory supporting system. And they've really been leaders in changing the way we think about child protection to an entitlement. And they've taught me that every child in the state of Colorado, every family in the state of Colorado is entitled to safety. It's something that is owed to them by the state. And so when they don't have the safety that they deserve, Health and Human Services in Colorado thinks, what have we done that has failed to provide that safety that they deserve? And I'm optimistic that with the new tools that we have and the new ways of thinking about things, that we can make a difference. But it means that we have to approach this not just with our professional training and expertise, but as citizens and voters and members of community to help really make a difference at a basic level. So it's worth asking, are these changes a net positive? You know, I tend to move towards research and progress and think of changes as a good thing that's happened. I'm an optimist, but I say that not as to fluff myself up. That's how I make mistakes, right? As an emergency physician, if you're always an optimist, you're going to make some pretty major mistakes. So we should ask, have these changes been a net good thing? Certainly, we have some challenges. We've got over-reporting, and that's a problem that we haven't really struggled to address that much. We still don't have objective methods to deal with the psychosocial data, which is both clearly related to abuse risk and which is clearly related and impacted by our intrinsic bias. You know, how do I approach the fact that someone is living with someone who just got out of jail for abusing another kid? It's important. How important is it? And how likely am I to be impacted by the fact that some people are much more likely to go to jail for that than some other people? It's not enough merely to identify that some families are experiencing multiple forms of family violence. We now need to move to addressing some of those wicked problems of different forms of violence that are occurring within a family. We need to establish connections within and beyond the House of Medicine and to partner with other professionals in order to care for families. But how do we do this ethically and maintaining our role as healers and not as agents of the state? And we really have to continue to grapple with some of these questions. But in the end, again, I'm an optimist. I'm optimistic about the next 20 years. Our best data that you can see on the screen shows that physical abuse has been steadily and significantly decreasing. And I think that these technological advances and the new thinking that they encourage is ultimately going to support a system that leverages data to make our care for children and families more objective, safe, and fair. Of course, the most exciting part of this is the changes that we don't know are coming. The advances that we don't know will come next, and the changes in our thought process that we don't know that we need to make. But I think that the progress that we've made so far and the systems that we're building and the partnerships that we have really makes me optimistic for the next 20 years. And I'm grateful for everyone who's attending this talk because I hope you'll all be part of it. Thanks. And if you have any questions.